Hi, everyone, and welcome to STAT's virtual event, The Pandemic's Toll on Mental Health, sponsored by Viatris. Thanks so much for joining us today. I'm Andrew Joseph, General Assignment Reporter here at STAT, and I'll be moderating today's conversation. And before we get started, just a few quick housekeeping items. You might be used to this by now, but at the bottom of your screen, you should see several icons. Use the chat feature to chat amongst yourselves or just send a message directly to the STAT team, and that appears as STAT events. Please don't put your questions in the chat, but if you do have a question that you would like to ask one of our featured speakers, please use the Q&A feature to type your question and we will try to answer it live. And we definitely encourage you to submit your questions if you have them. I already see one in there, so that's great, thanks. In the Q&A window, you should be able to see the questions that other attendees have asked, and you can upvote the questions you would most like to see answered. We'll be taking questions throughout the chat, so please, you don't have to wait until the end to submit them. Thanks so much again for all of you being here. And before we get started, I'd just like to welcome Dr. Anna Maria Jorga, Senior Director for Psychiatry, Pain, and Inflammation for U.S. Medical Affairs at Viatris, for a sponsored introduction of today's event. Take it away, Dr. Jorga.
Hello, good afternoon. My name is Anna Maria Jorga, and I'm a psychiatrist by training and Senior Director for Psychiatry and Pain for U.S. Medical Affairs at Viatris. Viatris is a new healthcare company which was formed last year to the combination of Pfizer, Upjohn, and Mylan. I'm very excited to open today's panel discussion to discuss the challenges we've seen related to the pandemic and the global impact it has had on mental health. I want to start by sharing that each year, 41 million people die from non-communicable diseases, or NCDs, including cardiovascular disease, cancer, diabetes, chronic respiratory disease, and other conditions. These patients are at heightened risk of developing COVID-19 and suffering from its complications. Vulnerable patients, including those with existing NCDs, need to be protected and assisted in responsibly managing their underlying chronic conditions, including mental illnesses. Perhaps what's the most significant about COVID-19 that it has revealed gaps where the system has failed to protect these patients who are at substantially higher risk of becoming ill and have a more severe course of illness and death. Barriers to mental health have existed long before COVID-19. The pandemic and our responses to prevent its spread have presented significant challenges to the continued care of patients with these chronic conditions due to isolation, fear, and other compounding factors. To better understand the impact of COVID-19 on those living with the NCDs, Viatris has partnered with Carenity, a global digital community supporting 5,000 patients and caregivers, and also separately with the International Alliance of Patients Organizations, and has recently surveyed nearly 10,000 individuals across high and low-income countries, including Italy, Spain, UK, Brazil, and the Philippines. While we're still finalizing these results, initial findings of the Carenity survey show significant disruption in care and overall health for many at-risk populations, especially young patients and those living with NCDs, with the pandemic taking a toll on their mental health. Many feel isolated and are adopting unhealthy behaviors as a way to cope with the stress of the pandemic. Results will be published in the Healthcare Journal later this year. However, what these findings do reinforce is the need to place a significant emphasis on mental health across the globe and for care that combines the social, psychological, and physical aspects of healthcare. We need a holistic, integrated care approach that looks at NCDs, communicable diseases, and emerging health crises by focusing on building reliable healthcare systems that support vulnerable populations. To put it pointedly, we need to promote a shift in the perspective from sick care to preventative care, where solutions are focused on root causes. At Viatris, we believe that the cost of instituting preventative measures around NCDs is far lower than it would be if countries did not invest in this type of care at all. This past May, Viatris and the partners at the American College of Cardiology will Heart Federation and NCD Alliance launched the NCD Academy, a free, interactive, web-based educational platform for healthcare professionals to improve the prevention and treatment of NCDs. We recently took the program to the next level by launching a series of mini courses specifically designed to help HCPs treating patients that have underlying health conditions during the COVID-19 pandemic. This year, we have plans to launch a series of lessons exclusively targeted at helping HCPs care for patients with mental illnesses. We also recognize the burden of NCD is evident across all countries, but that there are distinct differences among regions which suggest that the need for targeted intervention strategies. Viatris has also developed country-specific strategies and strong collaboration efforts with multi-sectoral partners to provide tailored solutions that address specific unmet needs and connect people to products and services. Our mission is to empower people worldwide to live healthier at every stage of life. And true to this mission, we are committed to continuing to bring resources to primary care physicians and patients looking to combat mental illness. Despite what COVID-19 has brought on, the world is interconnected and we are never looking back from that. As we look to the future, we have an opportunity to strengthen our health systems to ensure that they are set up for success long term. We need to build back better. Today's panel, which is sponsored by our company, brings together leaders from across the healthcare to help address these really important issues with the goal of identifying practical and pragmatic solutions for moving forward. Thank you very much.
Great. Thank you so much, Dr. Jorge. And now we'll get on to the editorial portion of today's event. I'm delighted to be joined by three experts who have examined and seen firsthand some of the mental health impacts from the pandemic. So please welcome Dr. Margarita Alegria, the chief of the Disparities Research Unit at Massachusetts General Hospital and a professor at Harvard Medical School. Dr. Jessie Gold, an assistant professor and director of wellness engagement and outreach within the Department of Psychiatry at Washington University in St. Louis. And Dr. Afzal Javed, the president of the World Psychiatric Association and a consultant psychiatrist with positions both at the University of Birmingham in the UK and at Fountain House in Lahore, Pakistan. Thank you all so much for joining us today. We really appreciate it. Dr. Gold, I was hoping to start with you, and this is a very big question, obviously, but I think it would just be helpful to start if you can tell us a bit about what mental health providers have seen throughout the pandemic so far, like the types of conditions or symptoms people are dealing with, whether these are new patients or existing patients who are having, exacerbated symptoms. Can you just tell us a little bit about what you've seen so far?
I will do my very best. Thank you for having me. Yes, it is a big question. So I'm a psychiatrist and, my populations of choice and the populations I mostly see are healthcare workers, their children, which for me is people above the age of 18, so college students, graduate students, and then their spouses. And a lot of what we see and we were seeing really right at the beginning where people were really just dealing with stress, trying to deal with their house, focus on adrenaline, not really worried about their mental health right at the beginning. We weren't really seeing a huge influx in people. And then kind of over time, I would say anxiety was really high because there's a lot of uncertainty, and uncertainty is the enemy of anxiety because you don't have answers to anything. So people are like, well, where do I go for this? How do I know when this ends? When do I wear a mask? Can anyone give me answers? And so the more uncertainty there is, the higher there is anxiety. And so lots and lots of anxiety. And then the longer this has gone on, I think we're seeing a lot more depression. And a lot of depression with not just because people have been isolated and that definitely causes depression from people being lonely and kept away from their jobs and their workplace in a different work environment, but just a lot of things have changed and it's really hard to cope with all of those changes. And there are a lot of stressors and a lot of grief and a lot of things that we're not talking about out loud, which contribute to things like depression. And then kind of in a lesser stance and things that we don't necessarily also talk about, I'm seeing a lot of eating disorders. And I think that's also increased. Some of that is people trying to find ways to cope, and sometimes with restrictive eating, it's a way to regain control, and that can be with eating and not eating. I've also seen an increase in substance use. I think that we're near our kitchen. It's a little bit easier access. I think at the beginning of the pandemic, some of that was even like a joke and a meme for people to say, I'm going to have a drink after work. And then the longer that's gone on, it's been a drink after work every day for a year. And there's only so long that you can do that. I definitely think in terms of the question about are they new or are they old patients, I've definitely seen both. So a lot of my older patients, I even had like a group of people who were doing quite well at the beginning and were like, well, Dr. Gold, I had therapy before, I had skills before. This is easy for me. I actually am quite prepared to deal with this. I can cope with journaling. I can cope with all of these things. But the longer it's gone on, I think it's been harder for people because there's only so much you can journal, you know?
Yeah.
And I think we're seeing a lot of people who were maybe able to cope, or I've had patients who were on the same medication for years and years who have come to me being like, is this the pandemic or do I need to adjust my medication? And we've had a lot of conversations like that. And quite frankly, it's hard to know the answer to that question because it's really nuanced. And some of the conversations are like, well, we can try it and see if it makes sense to try to adjust it and tell. But it's kind of a mix between some new people, some old people, but kind of both.
Dr. Javed, there's been obviously a wide range in how countries have responded to the coronavirus itself. Some much more successfully than others. And I wonder if there's a similar difference in how countries have tried to handle the accompanying mental health issues that have arisen during the pandemic. Have some countries done a better job addressing them or anticipating them, and other countries maybe haven't. They focus more just on the virus itself as opposed to these other issues that arise.
Well, thank you very much, Andrew. I think to begin with, I must say that this is really a global pandemic. And this is different from many other pandemics or epidemics. And the difference is that it is present everywhere. There is no culture, there is no country, there is no gender, there is no age which is immune or which is resistant to this particular infection. And then based on that, when you go from country to country, of course, you will have to really look at what are the prevailing medical facilities, what are the social net care work, and what are the opportunities for people to have an access to medical and social care. So obviously with these differences, the perception is different in different countries. The developed world or the Western world is more structured in terms of the healthcare delivery system. Whereas if you go to the low and middle income countries, then you will find that there is less emphasis on the delivery of care in terms of the community care. World Psychiatric Association has got a sort of a membership all around the world. And we are getting a lot of interesting feedback from our members. Some communities do not consider this as an infection. Some communities do not think that the medical profession has got an answer to this. And in many places, people are still going to native healers, traditional healers, or contacting those services which are not in the mainstream. And then superimposed on that, when it comes to the mental health is already marginalized. Mental health is still not considered a priority, even in high-income countries. And when it comes to the sort of the damage, the impact of mental health, that again varies from one country to another country. Just to give you an example, now we have got firm evidence that around 20 to 25% of the general population have got some type of mental health problem. Some people say 1 in 4, some people say 1 in 5. But looking at this burden of disease, what are the options available in terms of the care? Hardly 1% or 2% of the GDP of many countries. So there is a big gap. And this gap, unfortunately, increases when there is a disaster, whether a natural disaster or a man-made disaster. Immediately, the mental health needs go to the bottom list. And this is what we are seeing, that mentally ill, mental health problems, and psychological difficulties are really not considered the way these needs to be considered. And you're absolutely right that the differences are there from one country to another, or even from one part of the country to the other part of the country.
Got it. Thanks for that. And Dr. Alegria, I think just to bring it back to the U.S. a bit, at least one of the striking things about the pandemic, at least here, is that the impact has not been borne equally. There are big disparities in who's getting infected and who's dying. And I wonder if there are any signs of those disparities sort of carrying over into the mental health area, and like how researchers like you go about tracking that.
So thanks for that question, and thank you for inviting me to be part of this panel. It's a great opportunity. First of all, I wanted to say that, yes, we see the disparities not only in the COVID epidemic, but actually they are very parallel to the mental health needs of populations that we see right now. So for example, we see huge drastic needs in anxiety and depression, both of Black populations, Latino populations, and Native American populations. So huge disparities in terms of the symptoms of anxiety and depression. And like Dr. Gold said, we actually are seeing much more. We're seeing higher rates of suicide, of intimate partner violence, of sleep disorders. So it goes the whole way. I think we track it basically. For example, there's a lot of great survey data that's being collected in the US, like the Pulse surveys that are being done by the CDC. There's surveys that are done by other entities that collect this information. And so they look to see what's been happening. And what we've been seeing is, one, an increase over time, like Dr. Gold was saying. We right now have around 40 to 42% increases in people in the US reporting high levels of anxiety and depressive symptoms, which is really, I would say, pretty scary. And then second, we're also seeing higher rates of people reporting considering seriously intentions of suicide. I do want to go back to Dr. Javed. There's a lot that can be done. So I want to really talk about the opportunities, because this has really shown us that not everything is medical care.
Yeah, definitely. We'll get to that for sure as we look forward. Just a few more things about sort of where we are now. Dr. Gold, so you focus, as you mentioned, a lot on mental health and healthcare workers. And actually in an opinion piece for STAT that you wrote all the way back in last April, you wrote, quote, "Many healthcare workers are barely keeping it together. They are anxious and they are afraid. They aren't sleeping and they find themselves crying more than usual." And that was obviously at the very beginning of the pandemic. And so you called for institutions to start dealing with mental health for providers right then. And I guess I'm wondering, like, has that occurred in general, has that occurred to the level it should have? And sort of what are you seeing from healthcare workers right now?
Yeah, so that's a good conversation. So yeah, I wrote that piece for you guys in April. I was very grateful that you published it. I think a lot of people weren't talking about it or willing to talk about that early. It was right at the beginning of the pandemic. People who work in what I do and see what I see would have told you that mental health of healthcare workers was a problem long before COVID, and COVID just made it worse. We've always had some of the highest rates of suicide of any profession in physicians. We've had high rates of substance use. We've had high rates of depression. Training has made physicians depressed. And that's not just physicians. Nurses have high rates of burnout, of frontline healthcare workers otherwise would. We just don't have enough data, right? And I think we've known that. And if you look at the stressors of COVID, it was just an impending compounding disaster, right? So someone like me who sees those patients and knew that was coming would have just told you exactly what I told you in the op-ed in April, but you guys were the only ones willing to talk about it. And I think, you know, seeing this and then seeing it was a year and that it spread across the country and that it's still going on and that the healthcare workers haven't had a break. I don't know that I could have predicted that. I think when I wrote it in April, I was hoping that it would have been more contained and not been all across the country, and that they would have been able to have a time where they could sleep, and that they would have been able to say, okay, we got the curve under control, and that it hadn't been an onslaught consistently of like the highest rates of death they'd ever seen in the hospital, and nonstop no sleeping and worrying about getting infection and bringing it home, and consistent trauma, and, you know, this just like worry that they don't have enough beds or enough vents or enough supplies. And, you know, we just didn't have that end, right? And I don't think I could have told you that that was going to happen. And I think the just consistent and persistent heaviness that that's been for healthcare workers across the board, across the country, with like relentless trauma, I don't know that we know what that looks like for them. And we have a system where healthcare workers really have never sought help or like to talk about help seeking. We're really caregivers and not care receivers. We have a system where it's very stigmatized to talk about our feelings, where it's very stigmatized to ask for help for mental health, where our licensing still asks questions about mental health in a lot of states in a way that makes us feel like we're going to be punished, or our licenses could be suspended or at least monitored, or our licenses, the data might be used against us in some way. And it's just very confusing. And so this lore gets passed down where people just go, I'd rather just not get treatment. And that's why a lot of the time it ends up being a crisis or nobody tells anyone, right? And so it's a really dangerous situation. And so are people doing something about it? I think people are talking about it a lot more, and that's a positive. I don't think we've ever talked about healthcare worker mental health at this level. I don't think individual healthcare workers have ever talked about their own mental health at this level. If you look on social media, if you look in pieces, if you look on the TV and you see them crying, they've never done that before. You know, they're much more open to say, like, this is a problem. Like, I don't feel good. I'm not sleeping. This isn't okay. And that's different. Our healthcare system seeing it and changing, that's going to be a process that requires cultural change, that requires long-term investment, that requires knowing that you can't put a Band-Aid on this, that requires saying that this has been a year, but this is going to be years. And they can't say, I'm going to throw money at this tomorrow, and when the pandemic's over, it's over, because this, like, mental health outcomes for healthcare providers from this is not going to end when the pandemic ends. It's going to keep getting worse. So I think that we have to see that healthcare systems make investment in the long term in their workforce, or everybody's going to leave, or find a workforce that cares about them more. So I think we have to see that change. And I don't know that I've seen that everywhere. I've seen that some places, and I have seen the conversations change, but we have to see it more universally.
Got it. So we have a question here from Wesley Dean, and I'm going to combine it with one of my questions. And maybe Dr. Alegria, I'll put this to you. But so the question from the audience is, at our pediatric hospital, we've seen an influx of teens in crisis, as well as many cases of child abuse. If you touch upon the pediatric population, and I was going to specifically ask, you've written about mental health for kids as a result of the pandemic, many of whom have been out of school for a long time or lost, social connections. And also like disparities within that. So yeah, please, can you talk about that?
It's extremely serious for, especially we're seeing for emerging adults, the 18 to 26, that group is super high. But for kids, we're seeing a lot of problems in domestic intimate partner violence that the kids see because the parents can't leave the home. But we're also seeing that there's a lot of needed, social determinants that really put the family at risk. So I want to emphasize that they're the victims. They're not really the perpetrators, in the sense that we're having all of these families that are losing jobs, are losing, their daily routines, that are losing, family members. And certainly for the youth, we're seeing, especially for Black Latino children, escalating rates of like at the hospital, for example. One of the things is how high the numbers of reports of, parents just being stressed out with their kids and having problems with the kids. But again, I want to emphasize that they're part of the victimization that's happening in the US, that people are not getting sufficient supports, especially in low-income communities that are really dealing with, insufficient food, that are dealing with not knowing where to get. Like, take, for example, the vaccine. People don't know, it takes, a navigator to know where you have to call and where to get it. So these people are really suffering. I wanted to raise the same as Dr. Gold raised for the healthcare workers, for the essential workers that are going exactly, firemen, teachers, people working in the grocery stores. We work with them on giving them coping resources, and we're finding that they are really, really suffering. And the suffering is really transmitted to the kids to the effect that they're asking us, could you do the same that you're doing for us, for our children? And we're getting the pediatric units to ask us, can you please put in place things for the kids? Because they really are suffering from all of this routine changes in schooling, routine changes in family dynamics, routine changes in seeing a constant stress in their family. So we really have to pay attention to the youth. And, even we just recently did a meeting with people from Gonzales, and the students themselves were so much looking at mental health as a problem they were suffering, that they were able to convince the school to really get a social worker to help them out. The students themselves, that tells you what desperation there is out there for youth of color.
Got it. Yeah, I think so. You were referencing a city in Central California where that's populated mostly by immigrant families and farm workers, Gonzales, California, right? Okay.
Right, correct.
So you mentioned vaccines as causing as one cause of stress in the U.S. And just to take that in a different direction, Dr. Javed, in your role as president of the World Psychiatric Association, you wrote a letter to health ministers around the world last month, calling for people with mental illness to be included in vaccine priority groups. Because as you wrote, quote, people with mental illness are more likely to be infected by COVID, and that once affected, they have much higher mortality rates than the rest of the population. So can you explain why people with mental illness are more likely to be infected and have severe consequences by the virus? And are countries that you're seeing sort of accounting for that in their responses, whether their responses generally or with vaccine priorities?
Well, Andrew, to begin with, unfortunately, medical problems, medical morbidity is more common in chronic mentally ill. And there are many reasons for that. Social adversities, their lifestyle, their predisposition to many precipitating factors. And over and above, now there is ample evidence that mentally ill die prematurely as compared to the general population. So this is a group that is already vulnerable for developing physical health complications. Now, when it comes to the COVID-related sort of complications, unfortunately, all those vulnerability factors and predispositions are highly prevalent among the mentally ill. So if they get any infection, the chances are that their lifestyle, their socioeconomic status, their poverty, their deprivation, and so many other social factors actually increase the chances of their complications. So that is one major aspect. The other one is that despite COVID is now with us for almost more than 1 year, there is still a lot of uncertainty about the treatment. Nobody knows that with surety that, look, this is the gold standard treatment for this particular epidemic or pandemic. And that actually leads to a number of psychological distresses, even among those people who are not suffering from any mental health. So what we have been trying to preach to the governments that, look, generally there are three types of people who need urgent attention, especially with related to the COVID and mental health. The first one is that people who get infected, then this is a deadly virus that could have an effect on brain, on mind, on all parts of your system. So we do not know that what will be the consequences of nerve problems, mental health problems, brain-related problems. So that is one aspect of mental health issues with the COVID infection. Then, if somebody who is already suffering from a chronic mental illness, if he or she gets this, then the chances of physical complications become enormous. But there is a third group as well. And that group is fearful, that is anxious. They are worried that what will happen to them. I mean, as my colleagues are mentioning, there has been a very, very significant increase in anxiety, in depression, obsessive compulsive disorders, ruminations. I mean, all these things are increasing people's suffering. We generally say there are two very important areas or aspects, shame and guilt. Both these are linked to mental health problems in one way or another. So when it comes to COVID, unfortunately, it really increases the gravity. Now, coming to the second part of your question, that what happened? What happened when we try to contact different health authorities in various countries? So we were just trying to raise the awareness that, look, while you are considering priority groups, unfortunately, mentally ill are priority groups. And we have to really look at how effectively we can really approach them, convince them, and try to avoid from the complications. And I'm really pleased. In many countries, we had a very good.
Dr. Javed, we may have lost you for a second, maybe just a temporary signal problem. Hopefully you can come back or reconnect. I'm sorry about that. But it sounded like you were saying that there's a better response from some countries in terms of prioritizing vaccines for people with mental illness. So to take it in another direction, and this is a question from, Dr. Javed, you're back. Great, thank you. So to ask maybe Dr. Gold, because you sort of mentioned this with what you were seeing with your patients. This is a question from Marianne Marini. How to distinguish between like a temporary depressive episode due to COVID compared to the beginning of a more severe depression, which needs to be treated? How do psychiatrists like yourself sort of deal with this? And I think that gets to, there's a lot of people are feeling just sort of generally down or anxious or stressed, understandably. But I think, trying to distinguish what is sort of a result, just a natural result of being at home for a year versus sort of something more that should be clinically addressed. So how do you distinguish that?
Yeah, so I call that baseline COVID. I think the baseline COVID is not good for anyone. If you can point me to someone who feels fantastic right now or who has felt fantastic this entire time, I would like to be friends with them, or there's something wrong with them. I don't know, one of the two. But this has been really hard for everyone, at least this entire time at some point, right? So I think that we have to, one, adjust our baseline and say, at some point, this has been incredibly hard for all of us. So where is our baseline? It is not zero, right? So at some point we have had sadness, anxiety, anger, and happiness. So feelings are normal. Whatever we're feeling is normal. There is no normal feelings in a pandemic, right? So having feelings is fine. So we have to figure out what feelings are pathologic feelings, right? Which means the rest of the feelings, like the things that come with the feelings, are the problem, right? And how long have they been going on? So we look at the other stuff, right? So sleep, eating, functioning, concentration, suicidal thoughts, and not just like a day, right? Like a lot of people are like, I didn't sleep yesterday. Oh, I probably didn't sleep yesterday, right? But we're talking like weeks, right? So when we look at depression, usually the timeline is 2 weeks. It's a little bit hard sometimes to say that in COVID, because if you feel sad for 2 weeks, it can be a really hard time. So I sometimes say timeline matters, or how bad is it interfering with your day-to-day life, right? That's a really good measure. So it's super subjective, because what does that mean? That's like my life and my decision of what interferes with my day-to-day life could be some completely different with what interferes with your day-to-day life, but relationships, work, school, functioning, whatever, right? So if not sleeping for 2 days interferes with your day-to-day life, get help. I don't care. Get help whenever you need help, right? So not eating, not sleeping, sleeping or eating too much, not concentrating. Suicidal thoughts are actually more normal than we actually talk about. But, you know, if you've never had them before and you all of a sudden have them, that's more concerning. If you had them before and now you have them all the time, or they come with a plan or intent, that's more concerning. If you are not getting out of bed, not functioning, not doing work when you want to, that's more concerning. If your anxiety is so much that you like can't do things you want to do, if you watch a TV show and you used to like it and now you just are like, why is that thing on TV? This is the worst. Those are things that are concerning, right? Socializing is different now, but if your friends keep inviting you and you like to do a Zoom and you're like, I don't want to do that, that's also a sign, right? So things like that, that's interfering in your day-to-day life. I also say like irritability is also a sign. You don't just have to be sad or worried. So being pissed off is also a sign of anxiety or depression. So I'd put that on your like sign of knowing if something is wrong with me. And that's just a way to pay attention. So interfering with my day-to-day life, timeline, and then worsening or severity are kind of ways that I would think about it. If you've been sad before, if you've had depression before or anxiety before, and it feels like what you had before, that might also be something that tips you off. If it's in your family, that might also be something that's more like concerning for me. But, you know, those are kind of how I think about it. And then I would just say, you know, for me though, anytime you want help, get help. Like I'm a psychiatrist, so the reason to see me might be a little bit different than seeing other people, because I prescribe medication and I don't like to throw medication at people because it has purpose, right? But therapists and talking to someone and having a place to go to get help and work this stuff out, this has been really hard for people. So if you're struggling and you feel like it could be a benefit to talk to someone, I don't care what you call it. Get help whenever you want help. Like you don't need a definition. You don't need me to tell you like with a wand that something is diagnostically something, right? So if you're struggling, get help whenever you want it.
Great. I think one thing that's kind of emerged from a bunch of the topics you've all addressed is that, and I'm certainly guilty of this, sometimes thinking of like physical health and mental health, and they're in separate buckets, and or thinking of mental health as it's, you know, separate from things like, you know, food access or intimate partner violence, like you were talking about, Dr. Alegria, and, you know, Dr. Javed, you were talking about the connection between mental illness and COVID itself. And so I guess to try to move this to think a little bit more, to be a little bit more forward looking, you know, the pandemic has exposed in pretty stark ways a lot of problems in terms of health systems and inequities. And I wonder how it's done so in your view for mental health, like mental health system or the health system more broadly, and sort of like how things can be improved moving forward. And maybe Dr. Alegria, I'll start with you.
Yeah, I think there are many things that could be improved dramatically. I would say one of the first things I'll say is expanding the network of people that can provide mental health assistance. Because there's like Dr. Gold say, there's the clinicians, but we also train community health workers and peers that could actually do a lot of the job, especially at that first level where people are doing not well, and they're starting to feel like, you know, they can't really carry on. That's when we can intervene. I think the second thing I will say, it's so important to go to people rather than people to come to us. I think part of the group that we're missing, like Dr. Javed said, is people with mental illness that might not really feel comfortable going to seek care. We have to go to them and offer and encourage them to get some connection, to get some social integration. One of the things we know works the best in this area, besides obviously if you need medications, go get them. If you need, more serious professional help, but there's also the social integration of people in a connection of, there's actually a great program that was started, of, like, for example, Meals on Wheels, where they contact people, provide food for elders that are isolated, and make sure that they are not by themselves, and have someone, a contact person, that calls them and establishes a relationship. So I think making sure, that's a second thing that I would say. I think we really have to work on the policy dimension. People have talked in the chat about, regulations. There's many regulations that actually make it harder for people to get mental health care. Regulation of who can provide treatment, but more importantly, regulations about being able to move outside of your area, certifications that are very hard to get. So we could really think about how do we have to be more flexible about some of the regulations and certifications that we require for people, for example, to get substance treatment, getting buprenorphine or getting, methadone. So I think there are many things that can be done besides expanding the networks, expanding the regulations, and I think making sure that we do more social integration and move to communities either by mobile clinics or by people in the community that we can train to build capacity.
Yeah, just to follow up with you, Dr. Alegria, this is a question from Ken Walker, and I think it gets at the idea of how to better integrate mental health with the rest of the healthcare system. So how are primary care physicians being equipped to deal with the potential surge in those seeking help for mental health issues? Because that's where probably that first contact happens.
So I have to say that what I'm seeing with especially the primary care providers is they're themselves overwhelmed. They're not far behind with what Dr. Gold was saying in terms of being asked to do more and more and more, because people sometimes feel that's their only contact with the rest of the world. So I think we need to support them and integrate, have more consult liaison clinicians that could actually do the bridging between both sides of the equation. And not only that, I think with social services, we need to have a team approach right now, and that's what we should put in integrated behavioral health, where we have a consult liaison, we have a psychiatrist that people can go for consultation and for help if they need medications, a social person, as a case manager that can provide for social determinants, issues that people need to solve, like evictions. And then we need to make sure that those pieces talk to each other and to navigate the patient. I think that navigation of the patient to resources is badly needed.
Got it. Dr. Gold, I'm going to go to you next. You're talking about people obviously should seek out help, and like there are a lot of people seeking help right now. So I was going to ask about the mental health care workforce and how you all are doing. And in chatting with you before the event, you talked about how you're worried about burnout. People are working nights and weekends, and they're feeling guilty about like the wait list they're carrying, but that's just kind of where we're at. And so that's probably a reason why it would be good if people in other parts of the healthcare system were taking on some of that burden. But what is it like right now, and sort of what are the implications for the mental health care workforce?
Yeah, I appreciate the question. And I also saw in the chat that people said it's really nice that you're saying get help, but there's nowhere to get help. And I think this is really part of the problem, which is that as a mental health provider and in this like burden, like all we want to do is help people, right? And we know that there's nowhere to get help, right? The system is innately broken, and it's been broken for a long time. And all of us have said it's broken, it's broken, it's broken. And what you're seeing is an explosion of the break, right? Like it was breaking, and now there is a surge of people who need it, and it's just surging and surging and surging. And we've been saying, hey, it's coming and more people are going to need it. Help us, help us, help us. And nobody's helping. And there's only so much we can do, right? Which is that every therapist I know is working nights and weekends. Every therapist I know took back most of their clients that they had before that called. Every therapist I know like added in extra slots, and they're doing the very best they can. And then all of a sudden they burned out and they said, oh, wait, I'm a frontline worker too. I can't do this, because every single person is telling the same story. That is my life. And every person is making me sad too. Like there's only so much I can do, because there's a burden to my job as much as there is so much that I can care about, right? Like, and I think they don't want you to say, don't go see them, because it is so important that you go see them, and they don't want to scare you from seeing them because they're burnt out. That's not the reason to have this conversation. The reason to have this conversation is to say, they also are part of the conversation, which is they can only do so much to save the problem. And the wait list isn't because they are the problem. The wait list is because the system is the problem. So we have to fix the system to also help the therapist, because they're human too. And so don't blame your therapist that there's a wait list. They're trying the best they can. We're trying the best we can. This is, from what I've heard from people and from my own experience, the hardest time to be a mental health provider in my entire life. This is the most exhausting, the most, secondary trauma from people, and the most, we're also dealing with the world at the same time. And it's very hard to do this job, and we love it, and it's hard. So I think it's important to be considered too. So advocacy is really important. Having these conversations about who else can provide mental health care is important. Having mental health care in these conversations in every political arena we can, local, state, national government, is important. It is the most bipartisan issue that we have in this country, and it is completely neglected out of every conversation because people don't want to talk about mental health, and I think it's a stigma thing, and we have to stop that. We need to include mental health everywhere, and it is integrated into every conversation we have. We just tend to separate it for exactly what you're saying, which is we've been talking mental health, we've been talking physical health. They are the same, and we have to stop that. We have to put them in the same conversation, and we need to be in every single room because we should be. And we got to stop this, and we need to fix this, and we need to fix this tomorrow, not like months and years from now. Or all of you people who are telling me you can't get help now, just you wait for 2 months, 3 months, 4 months, 6 months from now.
Yeah, Dr. Javed, we were talking about sort of ways, problems in the US system and ways to improve that. I guess I wonder, you were talking about how a lot of countries may not even have like a quote unquote mental health system, or like that sort of this specific infrastructure that at least some countries do. So I wonder if the pandemic might have shown the need for that in some places, or if there's any way some things might start getting addressed in sort of a more positive way, or might be getting improved around the world.
Well, Andrew, I fully support what you are saying. Of course, disasters are disasters. Of course, when you get all these difficulties, you only look at the negative side. But I think we should also try to look at the positive side. Now, this particular pandemic and disaster has shown us one thing very clearly, that we need to have more preventive measures in terms of supporting people's mental health, supporting people's mind. As a psychiatrist, I always feel that when you talk about mental health, people will immediately start thinking about mental illness. So mental health is not only the mental illness. There is a box in between mental health and mental illness, and that is the mental well-being. So if you ask me that what message we can really get from this disaster, and that is a message for health professionals, for policymakers, for social workers, that we should try to incorporate the mental well-being concept in our lives. It is not that you are only trying to train yourself to be less anxious. Anxiety is a part of our normal life. It is looking at the positive side, looking at how can we overcome our problems in terms of disasters. And this is particularly true when it comes to those countries where there are less resources. I think we need to really develop curriculum. We need to really emphasize on our undergraduate, postgraduate, medical and social faculties that well-being is a subject, resilience is a subject that needs to be really considered a top priority in terms of the public health. And I always say, if you really want to face the mental health problems, you have to take a public mental health approach, and with a sort of a positive and well-being message. Somebody was telling me a very interesting interpretation that people always say, is the glass half empty or is the glass half full? I think there is no empty half, because the rest of if it is half water, the rest is filled with air. So this is the way you really look at that. How can we make our life more happy, more relaxed? There was a question that how do the panelists feel? I think the message which we would really like to say that these disasters will never finish. Our resources are not many to deal with these resources, but I think we have to be ready in terms of looking at personal, psychological, social consequences in a better way to overcome these problems.
I think, Dr. Javed, there's going to be a lot of focus, obviously, going forward on pandemic preparedness and how to prepare better for the next one. And I guess, is there a way to incorporate mental health into that, do you think? And how could you incorporate mental health preparedness into the pandemic preparedness?
Well, I think the most important aspect is that people talk about NCDs, non-communicable diseases. Now, mental health is a part of NCDs. So this means it is not only at the level of your practitioners, it is at the level of the policymakers. It is at the level of those people who are implementing those policies, that there should be a recognition that mental health is important. And that slogan, no health without mental health, is not just a slogan, it is a fact. So this is first thing, that we have to acknowledge that mental health goes hand in hand with the physical health. And then based on that, we have to really prepare our future planners, future therapists, future practitioners, that when they are looking at the problems, they have to consider that there is someone who is also feeling about the problem. So I think the most important thing, and this is what we professionals are really promoting, that please recognize and acknowledge the fact that we are not saying that cardiology or the heart problems, diabetes, obesity is less important. No, not at all. But we are just to say that while you are looking at the body, please do look at the mind.
Well, we just have a couple minutes left, and so I'm going to try to sneak in a few questions from the audience. Thank you so much for them. I'm sorry we're not going to be able to get to them all. Maybe Dr. Alegria, if maybe you can try this one. So in long-term care patients, so probably people at long-term care facilities and nursing homes, how is COVID-19 isolation, how have the restrictions tied to COVID-19 sort of influenced mental health among residents in the past year?
Well, we know that social isolation, and the longer you're socially isolated, the more the risk of mental health problems, serious problems. So this is where I was saying the importance of having people that can connect with you. So we believe in physical distance, but not social distance. This is where having, for example, giving people, one of the projects we're doing, we're giving people electronic notebooks so people can stay connected in nursing homes or in facilities that are for elders, so that they can have someone, in this case, someone that really talks to them and does cognitive behavioral therapy, but also gives them meditation, breathing exercises, exercises to try to stay fit without necessarily being there in place. So there are ways we could do that for our elder populations. That's really important. And for youth, I think it's so important that we do things for younger in the pediatrics, like people were saying, because this is a group that after schools, most of their mental health care was through school-based mental health services. And now that schools are closed in certain states, they don't have where to go. So giving confidential, anonymous lines where they can call and ask for help, like Dr. Gold was saying, would be the way to go, and making sure that they have a phone number or someone that they can provide them with mental health. I could not agree more with Dr. Javed in the importance of well-being. We're so much into the illness and not so much into the preventing the illness, so we don't have to go the whole way down the road.
One last question, maybe Dr. Gold, if you can try this one. Unfortunately, maybe a topical one. Has sort of the additional isolation and stress caused by the pandemic had an impact on people's ability to discern information and misinformation, which is obviously an unfortunate, part of the pandemic has been misinformation.
In terms of mental health, like, has it been harder for them to know that
mental health issues? Does that affect their ability to discern what might be misinformation?
I mean, I think when you're home and all you have is a computer and a television or nothing, it's going to be really hard to know what to know, right? And I think mental health is one of those things where a lot of people don't have access to information to begin with. And one of the reasons we're doing this panel and that we probably are involved in advocacy to begin with, I can't speak for everyone, I can speak for myself, is because there's not a lot of good information out there about mental health. I mean, I'm on Twitter for that reason. I mean, I see college kids all the time and people are like, well, don't college students know a lot about mental health? Isn't Gen Z like super plugged in, and don't they like to talk about their feelings? It doesn't matter if you like to talk about their feelings. It doesn't mean you know anything about mental health, right? I think that they don't know coping skills because they weren't taught that in school. Like, just like Dr. Javed was saying, we don't actually focus on wellness. We don't teach kids how to deal with stress. We don't teach them that when they're thinking about tests, that it's okay if they fail. We don't teach them how to deal with that or how to actually manage that, like feeling that they feel when they actually feel a physical manifestation of anxiety, right? Imagine if you learned that as a kid in school, what it would be like when you're an adult in the workplace. You wouldn't have to come to me wondering why my stomach hurts and why I'm not sleeping, because you would have understood as a kid that was anxiety, right? We don't know these things. We don't have the words for them. We don't learn feelings conversations at all as children enough to have those like conversations as adults. So, I mean, of course, misinformation gets involved because there's no information, right? And then on top of it, the conversations we have about mental health are so stigmatized. I mean, if you were to ask me, when have we talked about mental health in the pandemic? I can pinpoint a couple of things, and they're nearly all crises, and they're nearly all used for political gain. So, I mean, for the most part, we're using it in these big dramatic ways about anything related to suicide, anything we can use mental health to open up the economy or open up things that have to relate to like misused data. And, I mean, it doesn't mean they're wrong in a lot of ways, but it's never about prevention. It's never about ways to cope. It's never positive. It's never at all in the conversation daily in the same way testing and vaccinations are. You wouldn't know daily that people are struggling. And if you were at home alone, you would say, I must be by myself in this. I must be the only one who's sad. And as a kid, imagine what that's like. So yes, it's very easy to be misinformed and feel by yourself because nobody's talking about it.
Got it. Well, with that, I think it's time to wrap this up. Thank you to our event sponsor, Viatris, and thank you so much to those who tuned in today. And thank you so much, particularly to our panelists. It was really wonderful to have the opportunity to talk with you all. We so appreciate your time and your work going forward. And thanks to those who asked questions. Keep an eye out for our next STAT virtual event, which is March 12th, when my colleague Matthew Herper will be joined by 4 former FDA commissioners to discuss what the future might bring for the next FDA and the administration. More information can be found on our website, and be sure to sign up to join us. Until then, stay safe and be well, and thanks so much.
Thank you.
Thanks.